Hi, I'm Catherine Ayers-Wickenhauser from Direct Trust, and today I am so glad to be joined by one of our most recent interoperability heroes, Jay Nakashima from eHealth Exchange. Jay, welcome. Will you tell me more about yourself?
Yeah, you bet. Professional, maybe I'll just do the professional part and I'll keep my private life in the witness protection program or
Sure.
make it out to be something more exciting than it is. So I've always been involved in or always focused on interoperability. I started out outside of healthcare, working for IBM in Tokyo. And um, and again, it wasn't focused on any particular vertical like healthcare. But right then and there, I learned that getting two systems to talk to each other was super tough. And then I went to grad school and I moved into the payer IT community. And, we were all about getting the claims in the doors via or electronically via EDI and about trying to automate the prior authorization process and all that good stuff. And I was, working for payers wasn't necessarily my favorite. And then I went to work for two EHR vendors, and I really, really enjoyed that. And really, that's when I really got involved in clinical interoperability. And that's when the world was still doing a lot of its documentation inside hospitals and provider ambulatory practices, on paper. And the world was really impressed with the promise of clinical interoperability for a variety of reasons. And then I went to work for a national payer in charge of their clinical IT strategy. And of course, clinical interoperability bubbled right to the top of our priorities. And that ultimately led me to the eHealth Exchange, where I've been for the past 6 years. And I've really been able to double down and focus into make it ensuring that data can be exchanged and scale at the national level.
And it's always so intriguing to me because I feel so many people have different ways that they've come into the health tech space and into the interop space, but often for a lot of us, it does come back to an electronic health record vendor or some other vendor for us to move into this interop space. And you mentioned you've been with eHealth Exchange for 6 years. So can you tell me more about your time at eHealth Exchange and your experience at eHealth Exchange?
Yeah, absolutely. So eHealth Exchange is a network. It was actually founded by a group of federal agencies and then some organizations in the private sector like Kaiser and I think the East Tennessee Health Information Network and the Utah Health Information Network, Dignity Health. And it was called the National Health Information Network, or NHIN. And it started as an ONC, an HHS ONC initiative. And then when it was time for ONC to say, hey, this project was successful, we're going to turn it off. As I understand it, its participants, healthcare organizations, kind of cried bloody murder and said, we can't turn it off. So it was moved over to the private sector as a nonprofit. And I was super curious. I've only worked for for-profit companies, and I've always wondered what in the world does a nonprofit do? Do they play golf? Do they go to matinees? So I came over to eHealth Exchange and I found out very quickly it's a business just like any other. You've got to bring in the revenue and you've got to add value and you've got to pay your bills and all that good stuff. And so, but eHealth Exchange is fortunate in that we don't have any shareholders. So we don't have to worry about creating a profit that we can return to them. Instead, we operate for the public good, and any excess money that we bring in, we're able to reinvest for the public good. So it's a network. So it's a group of healthcare organizations, 5 federal agencies, 60 state and regional HIEs, about 280 large health systems, and some other odds and ends. And we've all agreed to exchange data the same way. So we all sign or everyone signs the exact same trust agreement. Everyone uses the same technical specifications, and everyone follows the same rules of the road.
Mhm.
And eHealth Exchange has gone through, a couple of transformations, but, I think the biggest one was, 5 years ago, we implemented a new tech platform. So before that data, there weren't a huge, or there weren't as many what we call participants exchanging data,
Mhm.
and it was more practical for them to exchange data directly. But anyway, 5 years ago, we implemented a new hub and spoke tech platform. So
Mhm.
all data goes through the eHealth Exchange centralized platform. Um, and I really think that's what laid the foundation to move us. So 5 years ago, we were exchanging about 20 million transactions of clinical records a year. And in 5 years, we've gone from 20 million annually to 20 billion annually. So, the amount of data exchanged has really skyrocketed exponentially since we implemented that platform.
And of course, that data exchange represents patients and hopefully decreased burden of providers and care teams and better care for patients. So that's really exciting, and what an incredible milestone to reach. And I'm sure it's only up from here. It's interoperability just keeps on growing, right?
That's right.
So, and for I
And
think
sorry to interrupt. That brings up a good point. The vast majority of the data we've exchanged is exchanged for treatment purposes. So, under the HIPAA definition, think about a clinician at a bedside or in an ambulatory practice at the table side or the chair side, saying to him or herself, "Hey, I should probably look at this patient's history and
Mhm.
collect data from the outside world before I make a care decision." And that's wonderful. That enables these providers to make safer, more informed decisions. But we really, as an industry, have not done a great job at exchanging data for other HIPAA purposes of use, for healthcare operations, for payment, for research, and so on and so forth. And I think that's where the industry is going to be headed over the next, I don't know, 5 to 10 years.
And we certainly know, I think, working especially in this nonprofit network for the public good space, I'm right there along with you. And um, we have no shortage of opportunity, right, to improve. And we've seen, just like you outlined, we've seen so much growth as an industry. And it's exciting to think of these additional purposes of use and interoperability really continuing to grow, and how much better hopefully things will be in a few years. So we just experienced one of those revolutions, I think, with COVID. Obviously, COVID kind of changed the way that we do business and interact with each other, and certainly accelerated, I think, the need for interoperability. So I'm curious from your perspective, when you think about, what eHealth Exchange went through with COVID and just that timing, are there any evolutions from that time that you're particularly proud of?
Yeah. Okay. Well, I should probably start by saying, you're right. It was a big pivot period for the whole country. And,
Right.
if you think back to, I think it was what, late February, early March 2020. And, we're all hunkered down in our home offices with our families. Our kids are not going to school. our spouses are not going to the office. And besides the, people getting sick, I loved the quarantine where we were locked inside for, I forget what it was, 6 to 12 weeks or whatever. Every day you'd wake up and there'd be some new learning. One day you're disinfecting your groceries outside. The next week you're wearing a mask. You're doing Zoom games. If you get in your car, you see these makeshift tents outside of hospitals. Um, I remember one medical device manufacturer who donated a ton of CPAP machines, thinking they could be used by the hospitals for as ventilators. But you never knew what to expect. But the point I'm slowly trying to get to is, during that quarantine, so in February, March, April of 2020, that's when, a day late and a dollar short, that's when we really began to focus on submitting electronic case reports. And again, right or wrong, we had been focused on getting more data for treatment to be exchanged. And even though I've been in health IT for 30 years now, I was painfully ignorant and didn't understand how completely starved for data public health agencies were, and how rudimentary some of their data exchange processes were. Send your Excel file directly to the White House via email. I mean, again, it was comical, but at any rate, during that time frame in the spring of 2020, we went heads down working with APHL, the Association for Public Health Laboratories, and CDC, and then public health agencies in all 50 states, saying, how can we get electronic case reports to the public health authorities? And so really, really quickly, we're talking about within weeks instead of within months, we were able to implement electronic case reporting. And electronic case report is more than just a lab result. It's an entire report that electronically might say something along the lines of, hey, patient J was or did receive a positive COVID test. He was prescribed I'll make it up. He was prescribed horse tranquilizer or horse medication to help with it. He was admitted to a hospital. He was then moved to a critical care unit. He was put on a ventilator. And then hopefully he was discharged. Hopefully he didn't die. But at any rate, this information started going to thousands of public health agencies all across the country within a matter of weeks. And I forget how many, I'll call it state-ish public health agencies there are. Let's say there are about 54, 55. But above and beyond that, think about in your local community, you've got a XYZ county public health agency, and maybe even a city public health agency. And APHL has been wonderful. They are the ones who they have their system go through the brain damage of figuring out where to route those public health reports. So as an example, state XYZ may want COVID reports, but maybe not Mpox reports. And maybe the county of whatever does want it or doesn't want it. So we were able to route that really quickly during the quarantine. And then, now that I think about it, another one I might mention is FDA exchange. So I think we started this during the actual quarantine, but it definitely moved more into the summer and throughout later in 2020. But we helped the FDA. So the FDA joined eHealth Exchange very quickly as a participant. And they were struggling because they needed to collect data related to adverse events, especially related to vaccines, immunizations. And so they were able to deploy to connectivity again within weeks, not months, in 46 states, where they're able to automatically receive notifications that, hey, patient J was received a vaccine. He appears to have had a reaction to it, and they're able to automatically push that our participants to the FDA in 46 states, and not via the legacy way of CDAs or CCDAs, but using Fire R4, so using a brand new connectivity platform.
Mhm.
Um, and then once FDA receives those notifications, they're able to query back via Fire R4 and say things along the lines of, hey, you said patient J had an adverse reaction. You mentioned hives and a fever and whatever else. But they're able to query back and get close to or get the information they need, which I think is pretty darn close to the entire patient medical record.
Mhm.
So COVID was a big year. It really pushed us further into a public health exchange, which really fits great with our mission. So, we're all in on public health these days.
Good. And that's so good to hear. I mean, I think we all realized during the pandemic how much more we needed to invest in some infrastructure. And that's also why organizations like eHealth Exchange, like Direct Trust exist to, help facilitate moving some of these things forward. So thank you for sharing that. The electronic case reporting was so critical and continues to be so critical, as well as the adverse events and growing.
Yeah, and direct trust plays a huge role in electronic case reporting. I forget what the exact stat is, but I want to say it's something like half
Mhm.
are routed are transmitted via direct secure messaging.
Yeah, and we could have a whole separate conversation around, what that looks like and technically how that works. But one of the things that makes me really excited about health IT and the interoperability space really is that team interop approach. Knowing that we have different initiatives, even different standards, and there's opportunity for them to work together. And so I'm glad you brought up the electronic case reporting because I think that's a prime example of networks and entities coming together to make something happen and make something happen quickly. And speaking of, networks working together, you also have been designated, eHealth Exchange has been designated as a QHIN, so Qualified Health Information Network, as part of TEFCA. And so I'm curious, this has been a big topic of conversation in 2023 and 2024. But I wanted to get your thoughts as Jay. So do you think that TEFCA will solve interoperability, or as we've kind of entered this new time where we do have designated QHINs, do you have any other predictions or things that you see coming?
Yeah, great question. Um, so I do think TUFC is going to be successful. I do think it's going to move the needle. I think we're going to go from making little baby steps and improving data exchange to giant leaps.
Mhm.
Um, but it's not going to happen overnight. And so I don't know if I would say it would solve interoperability because everyone has a different idea in their mind about what's broken or how it could be improved.
Mhm.
So I personally get frustrated when I hear that data won't move.
Mhm.
But then I often have to remind myself that there's a balance with patient protections
Mhm.
that probably aren't going to change in HIPAA anytime soon. And those protections are what often limit or serve as the guardrails for how and when data can be exchanged. And TEFCA does not override any of the HIPAA requirements or obligations. Um, but again, I think TEFCA is really going to move the needle. And, I think the big reason for that is that, it would be crazy for us or anyone to underestimate the government's ability to implement change.
Mhm.
The government, even though TEFCA is voluntary, at least for now, it is absolutely spurring innovation, and there is a little bit of cover for organizations to say, "Hey, I've been exchanging data as part of the TEFCA framework." A government-sponsored, um, uh, trusted exchange framework. Um, and so, one of the real beauties here is that TEFCA is putting tremendous emphasis on non-treatment purposes of use. So it's saying, hey, data is being exchanged really well for treatment purposes, whether providers know it or not. Sometimes providers look in their system and they don't necessarily understand where the data may have come from.
Mhm.
But regardless, TEFCA's doing a really nice job of focusing on exchange for public health purposes, for individual access. So, giving individuals the ability to retrieve their own personal data, and then public health. We don't have a final date when public health is going to be required for exchange under TEFCA, but it's absolutely permitted now. And so eHealth Exchange is spending a tremendous amount of time and effort focusing on that broadened public health exchange. And then payers. So I think a lot of people don't realize a lot of that that payers and providers are very actively exchanging data. They're just not doing so in a standardized, scalable way. And so I'm really hopeful that that's something that TEFCA is able to focus on next. So again, TEFCA permits that payer-provider exchange,
Mhm.
but it doesn't yet define a lot of how it must occur. And so that'll be exciting once it begins.
Yeah, certainly. I think a lot of the conversation today has touched on opportunity and additional purposes of use, right? So continuing to see interoperability grow and knowing that that has tremendous impact in multiple different ways. It's really exciting to see, and I'm sure you are aligned with me when you're excited to be in this work and do this work. And so thank you for sharing your background and your experience with eHealth Exchange. And to close out our conversation today, can you offer any final thoughts or even words of wisdom that you might have?
Uh, yeah. So, I guess I would say that those in the healthcare space really don't need to wait for new regulations or new standard operating procedures to be defined. There's a lot we can do a lot better with data exchange with what we have today. Um, and yes, the technologies are imperfect, the laws are imperfect, the policies are imperfect. Um, but we can really move the needle today. And then as the technologies, the policies, the frameworks like TEFCA move forward, we can even do more.
Mhm.
So perhaps a way to paraphrase that might be to say, if you can't fly, then run. And that's certainly not my quote. I think that came from MLK back in the mid 60s. But yeah, if you can't fly, then run.
I love that. And I think that's a perfect note to end today's conversation on. So thank you so much, Jay, for sharing more about yourself and your experience with eHealth Exchange.
Yes, my pleasure. Thanks for having me.
Sure. And to find more Interop Hero videos like this, visit directtrust.org/Interop Hero.